Good day, everyone. For this next lecture, I will be talking about some management principles of anterior segment trauma. With this lecture, I hope to be able to impart some important points for the general ophthalmologist so we can be better equipped to manage patients presenting with different types of trauma involving the anterior segment of the eye. I'm sure all ophthalmologists would agree that we have all seen our fair share of ocular trauma cases. This is especially true during our training, when ER referrals during our duty nights would often involve an ocular trauma patient. Despite trauma being widely considered as a preventable disease, it is still very prevalent today. US statistics point out that at least 90% of all eye injuries are considered preventable, and yet 38 to 52% of cases presenting in the ER involve eye trauma. This disease is considered one of the leading causes of monocular blindness and second only to cataract as the most common cause of visual impairment. In the Philippines, published data from PGH and in East Avenue show that in adults, eye injuries occur most frequently among young adult men who are involved in manual labor. These are usually work-related injuries and are often penetrating or open globe injuries, such as a nail flying into the eye while hammering, causing a corneal perforation. In contrast, among the pediatric population, ocular injuries happen primarily at home, with blunt trauma being more common than penetrating injury. In actual practice, we have all seen this scenario wherein underneath a bruised face and a black eye is a more complex injury involving different ocular structures. It may involve penetrating or blunt injuries to specific tissues of the eye. There may be signs of infection or involvement of foreign body material, or any random combination of these. As there are several possible permutations of ocular trauma presentations, diagnosis and management may sometimes be a challenge. Therefore, it is important to remember some key principles in ocular trauma management so we can organize our thought process to be able to arrive at a proper diagnosis and treatment plan, which includes proper referral to subspecialty services as needed. Since we are dealing with trauma patients, it is important to first ensure that all life-threatening conditions are first recognized and addressed. Once the patient is assured to be in stable condition, the ophthalmologist can then proceed to examine the patient using a systematic approach. It is important that we be as thorough as possible with our ocular exam, but to create the least manipulation of the eye as possible. First, we need to take a good history. Similar to any trauma case, the basic information needed includes the time, setting, and mechanism of injury, and any previous treatment received. For ocular trauma, we should also ask for past ocular history to account for any possible manipulation in the involved eye prior to the current injury. For penetrating trauma, it is important to note specific details with regards to what hit the eye, the size and the type of object, and how fast or hard was the impact, to give us an idea of what to expect during the PE. For penetrating trauma, we should also ask if the object in question was retrieved in order to support or rule out a possible intraocular foreign body. For burn injuries, history should include details on what caused the burn, especially for chemical burns. It is also important to note that for acute injuries wherein the eye is still exposed to the offending agent, prompt institution of emergency care should be prioritized over completing the interview. For children or for incapacitated patients, details of the injury may be asked from watchers, relatives, or any person who might have witnessed the event. For the PE, we proceed with a sequence similar to the basic 5-point OFTA exam. However, we should defer tests that put pressure on the globe, such as tonometry, force duction testing, and scleral depression, for the obvious reason that excess manipulation might further exacerbate the damage. There's also special emphasis on the baseline VA, since this is considered to be the most reliable predictor of the final visual prognosis after treatment. This will also help the physician set the expectations for the patient when discussing treatment options. For this lecture, we will focus on the pertinent details of the anterior segment exam and zone in on the following key points. First, our approach to examination should be based on anatomical arrangement of structures. You can start by looking from the outside going in, noting any damage seen in the conjunctiva and sclera, then moving on to the cornea, anterior chamber, iris, and lens. Once you have identified the damaged structures, you need to assess the extent of the damage, which can range from small tissue breaks to very large gaping wounds. Using our knowledge of basic ocular anatomy, we should also check for possible damage extending to adjacent structures. For example, corneal lacerations extending all the way to the limbus may even extend further to the sclera. Prolapsed tissue is a sure sign of a full-thickness break and extensive damage, so make sure to account for all possible structures that may be involved, including implants such as in this case. Mucoid discharge or debris might also cover significant findings, so make sure to clean these up during examination. Foreign body injuries also warrant special attention and thorough investigation. Materials that come into contact with the eye can come in different shapes, sizes, and depth of penetration. This information is important for planning surgical removal. These details may be seen outright. However, if there is limited view of the foreign body in question, diagnostic imaging tests can aid in the diagnosis. Suspicion of a metallic intraocular foreign body can be supported by even a simple skull X-ray. For delayed referrals, infection may already have set in, which will necessitate additional management. In such cases, diagnostic tests may also be helpful. Here, the presence of fibrin in the AC is a sign that there may already be endophthalmitis, and a B scan should help confirm the diagnosis. As general ophthalmologists, we should do a complete exam for all trauma cases, including screening for pathologies beyond the anterior segment. This includes the ocular adnexae, the orbit, EOMs, and the posterior pole. Depending on the mechanism of injury, trauma can result as a continuum of damage involving external as well as internal structures. An eye damaged by trauma is left with decreased or lost vision, and rendered unstable due to disruption of ocular tissues. This instability can lead to further complications down the line, such as infection, inflammation, further structural changes or tissue loss, and glaucoma, if left untreated. Therefore, in treating ocular trauma cases, we must keep in mind that our first priority should be to stabilize the globe, and to try to restore or at least reapproximate to the best extent the normal anatomical configuration of the damaged ocular tissues. Ideally, restoration of vision is also included in the initial management, but in certain circumstances, this can be delayed until more favorable conditions are met. If the eye needs surgery, the surgical plan should include corrective actions for all damaged structures seen in the examination. However, we do not need to fix everything in one sitting. We have the option to do staged procedures depending on a case-to-case basis. And despite a well-thought-of surgical plan, unexpected findings may be encountered intraoperatively, leading to changes that may have to be made on the fly. With more experience, surgeons can develop better anticipation of these inter-op changes. But for beginners, it is best to have your seniors around you available for referral if needed. As with examination and diagnosis, the treatment plan should be organized based on anatomy and extent of damage. For conjunctival lacerations, large gaping defects are sutured for better wound approximation, while small tissue breaks can heal spontaneously and may be managed conservatively. Corneal defects should be corrected with watertight closure and removal of tissues which should not be attached to the cornea. Prolapsed uvea should be excised if non-viable, and vitreous should be removed from the anterior chamber. These corrections are ideally done with as minimal distortion to the cornea as possible. However, if the damage is certain to lead to scarring or astigmatism after the repair, secondary procedures can be done to improve vision. If the corneal defect is too large and direct apposition with sutures is not possible, options for repair include plugging with cyanoacrylate glue or using donor cornea for patching. For blunt trauma, medical management is initiated to address corneal edema, anterior chamber inflammation, and IOP increase. Aggressive pressure and inflammation control is especially important in the presence of significant hyphema in the acute setting. For scleral involvement, the exact extent of damage may not be visible during the initial exam, so wound exploration may be needed to expose the whole length of the laceration. If the cut extends past the pars plana, then there should be a suspicion for posterior pole involvement. Thus, it is advisable to have a retina specialist on standby in such cases. Any prolapsed vitreous may be excised, while uvea or retinal tissue may be reposited before closure. If lacerations cross between the cornea and sclera, the repair can be done by first opposing the limbus to establish proper orientation of tissues. This is followed by closure of the corneal component, then the scleral component. For iris defects, if there is enough viable tissue, you may opt to attempt repair using the appropriate pupilloplasty techniques. However, in cases where there is not enough uvea to work with, you can explore other options for artificial restoration of the pupil, such as printed contact lenses or iris implants. Lens involvement is usually a cause for considering staged procedures. A traumatic cataract or dislocated lens may not be easily accessed, or implanting an IOL may not be feasible in all cases. The timing of these surgeries will depend on adequate view of the cataract, as well as surgeon's experience, skill, and preparation. In this case, an anteriorly dislocated lens is easily appreciated, thus a straightforward ICCE can be done. But when combined with a corneal perforation with iris prolapse, surgery must be done in stepwise fashion. The cornea must be repaired first to stabilize the anterior chamber. If there is adequate visualization of the cataract, you can proceed with extraction using the surgery of choice. If the capsular bag is intact after cataract removal, you may even go ahead with implanting an IOL. However, if during cataract extraction a posterior capsular rent is noted, the surgical plan can change inter-op. Anterior vitrectomy should be done and the eye may be left aphakic. A secondary procedure can then be done once the eye has recovered and the appropriate method for IOL implantation is chosen. For foreign body injuries, assess the depth of involvement, then decide whether it is safe to remove under the slit lamp or if it will be better accessed under controlled and sterile conditions in the OR. Shallow injuries such as this grinder trauma can be safely removed in the clinic. But for deeper tissue involvement, removal should be done in the operating room with a complete plan to repair all damaged structures. This broken drill bit pierced its way through the cornea and embedded in the lens, requiring repair of the perforation and cataract extraction after removal. If the damage or foreign body involvement extends beyond the posterior capsule, it is best to have a retina surgeon on standby for referral if needed. As mentioned earlier, initial treatment of traumatic hyphema is medical management of inflammation and IOP. But for persistently elevated pressures and/or non-resolving hyphema after a few days, AC washout is needed. This may be attempted with INA instruments, but for thicker and more adherent clots, an anterior vitrectomy cutter may also be used to facilitate easier evacuation. For complex cases with extensive damage and very poor baseline vision, the surgeon must assess whether or not it is still worth pursuing repair. If there is no realistic chance to regain functional vision despite multiple surgeries, it might be better to enucleate the eye, which would also decrease the chances of developing sympathetic ophthalmia in the good eye. If the traumatized eye happens to be the good eye or the only eye of the patient, then we may opt to be more aggressive with repairing, but we must also manage the expectations of the patient. Compared to penetrating and blunt trauma, burn injuries do their damage primarily on ocular and periorbital surfaces. But among the different types of burns, chemical burns are considered a true ocular emergency because prompt removal of the offending agent is mandatory in order to prevent complications that can be a source of chronic discomfort and burden to the patient and lead to eventual vision loss. As mentioned earlier, emergency treatment with copious irrigation should be initiated prior to complete history taking in acute cases. After emergency treatment, or in cases of delayed referral, management shifts towards inflammation control and adequate lubrication to facilitate healing. Thermal burns, on the other hand, may be less severely damaging to the ocular surface since heat exposure is usually very brief and is minimized by the protective eyelid reflexes. However, this means that we should also be mindful of burn injuries to the periocular skin. Management of the ocular surface is similar to that in chemical injuries, but with allowance of less urgency. Finally, we should also review ultraviolet photokeratitis, since its prevalence has increased during the COVID pandemic due to increased usage of UV sterilizers. Patients may come to us presenting with eye pain and epithelial defects, and they may not be aware that it is caused by directly staring at UV light. So we must probe for exposure during history taking if there is a high index of suspicion. Management of such cases consists of lubrication and pain management. So to tie up the lecture, we recognize that anterior segment trauma can present in a wide variety of forms and severity levels. But any of these cases can be properly managed by ophthalmologists by taking a good history and conducting an organized, comprehensive, and careful examination to be able to identify all significant pathologies. By doing this, you should be able to arrive at a complete diagnosis and formulate a sound management plan with the necessary steps executed at the right time. Our approach should be anatomy-oriented and comprehensive, with the goal of stabilizing the globe and ocular surface to prevent further complications. Once that is achieved, we can then have the best chance of working towards improvement of vision. Before I end my lecture, I would like to thank my colleagues and our patients in the Philippine General Hospital, Quirino Memorial Medical Center, and Rizal Medical Center, who helped provide the content for this lecture. These are my references. Thank you so much for your attention.